well. Go ahead.
Yeah, maybe we could just start with questions. It's very interesting how we all conceptualize abuse and how varied this is, and we could go from there.
Terry Fulmer, I think this was a fabulous panel, and it just accelerates the great work going on. I loved it. And I want to personally thank Scott, who has been so good in sharing the technology. We ended up converting our R21 procedures to Akasi because of his work. So thank you for that. So a couple of points I wanted to ask about, and I want to also say to Mark Yaffe, it's great that you're thinking about the way that not only physicians but clinicians in general will be able to use the screens. I think one thing to add to our thinking is we have interviews and then we have physical assessment. And so in our work with an elder assessment instrument gets very clogged up because some people won't take their clothes off to get screened. But I think we're going to have to wrestle with that. I want to point out to the group that Wasson and Jetty did a nice paper on single item screening, and it was around women's violence, and that no matter what we do, if we leave this forum and get everybody to ask one question, is there any abuse or neglect you want to tell me about? We will have made great progress. So the last thing I would say is that I like the point made about directly asking older people. Scott's last slide, so informative about what we need to be asking. And I think that another form that we need to be looking for is this notion of unnecessary restriction as a form of elder mistreatment and neglect. So it's exciting, and aren't we lucky that CMS is moving ahead with this? Thanks.
A couple of comments and maybe an offer of synthesis here. I hate to go against Terry Fulmer, but I'm going to say the single question, though tantalizing, evidence has shown that it's dangerous because you feel like you're doing what you need to do and you don't. And we know, for example, the question, have you ever been raped, will get 1 out of 5 rape victims if asked as only that. Whereas anything bad happened to you, which is what the Bureau of Justice statistics used to ask, will get about 1 in 10. What Scott has presented and what Mark has presented and the work that we did with RDD, I think what we bring to the table is very specific, broken down element questions. And I think what Mark brings to the table is a way to actually do something that's clinically relevant in the context of a 5 to 15-minute visit. But technology will allow us to synthesize those two things, the very specific yes-no questions. You know, we teach interviewers in medical school and psychology school to ask open-ended questions, but the opposite is necessary here. We need yes-no answers. But if we were to adopt Scott's method and make these interviews tablet-based, which is happening, I don't know if anyone's gone to the doctor's office where that's happened, but in a couple of my more recent visits, I was handed a tablet. And that allows you to use the best questions because Mark's thing is great, but the sensitivity was 50% for a screen. Now that should scare you because that's too low for a screen. It should be 90% with a second follow-up that can get there. But Scott's strength in his method is sensitivity and double what we found. And then he replicated what he compared it, and it was still double, which means I believe his method is far better than our method and the other methods. But his method is a hybrid because there was an interviewer. It wasn't an automated system. It wasn't a phone call that you got on the web and logged on. There was a person there. But that person, like in a doctor's office, handed the person the tablet or the computer and removed themselves. So you had both the personal touch, the caring individual, they probably said hello and were nice, and you had the
Hopefully they did that.
and you had the automation so that you could do something. And so I would hope that we would not consistently, as someone said the other day, reinvent the wheel with a new screen or new definitions, which is frightening. We have basic building blocks. We have what has been demonstrated as a phenomenal way of detecting it. We have the setting where you've shown you can do it. And really, if I hope anything comes of this, is that people get together and combine those two methods. You're sitting next to each other on the days, and I hope this actually can result in some sort of exportable product.
Yeah, I mean, the one thing I didn't get to because she flashed the 2-minute sign was I know that for the work we do, I mean, I'm a large scale sample statistician person, so I think of prevalence studies, and I was thinking, well, boy, to use this, you'd have to, and do a massive in-home interview study. We used to talk about piggybacking a couple of questions onto an existing survey, like the HRS Ahead collects all kinds of data on financial issues. It'd be great to add a couple of questions on financial mistreatment, but of course, those studies are very sensitive to, to doing that context effects and so forth. So yeah, I think I always worried that yeah, it's great, but it's kind of impractical. It's very expensive to do in-home surveys, but taking it into the clinic, I think, and as I say, Terry has done some work in, I think, waiting rooms and dental clinics.
I could add just one point back with Ron and, the point about the capacity to capture things in a single item. Here's how I think about that. I'm trying not to do this, but not too rude. So if you get 1 out of 10, you got 1, and maybe that would change a clinician's behavior. So I agree with you, but my starting point is nobody's asking. And so your data are correct, and 1 out of 10 is better than 0 out of 10 as a start, and let's keep working on it.
Jim O'Brien, Louisville. I want to mention a type of abuse that hasn't been discussed. The setting is a hospital, and the perpetrators are usually physicians and family. Older adults who are dying in hospitals are frequently subjected to futile and excessive care that results in pain, suffering, and a loss of dignity. The care is so fragmented now that typically the number of physicians involved at the terminal phase may actually exceed the number of organs that somebody possesses. And there's absolute chaos. And maybe it makes a case for why a geriatrician should maybe oversee the care during the final phase. Palliative care is wonderful, but they have to be consulted before they get involved. I'll just briefly mention a case I'm familiar with. A 94-year-old woman who was featured in our program as an example of successful aging, now is moderately demented, developed for a couple of years had chronic lymphatic leukemia, which was asymptomatic. I mean, periodically needed some transfusions. And then entered an acute leukemic phase. Hospice was discussed with the family. There are 2 malignant children who are involved. And everything must be done for mom, whether it hurts or not. So go through a bout of chemo, which has very deleterious effects on her health, becomes much more immobile and subject to recurrent infections, etc. That's followed by a fall where she sustained a fractured hip. Hospice discussed again, rejected, had her hip repaired. It was amazing. And but there's always somebody willing to do it. And then subsequently fell again, developed a subdural hematoma, now is lethargic, is not eating, and has developed pressure sores. So will now die a relatively painful death. And I think it's a huge issue. It probably happens in every hospital in the U.S., and we can't ignore it. It's the most serious, egregious form of abuse. So,
we'll take one more question, perhaps from Bridget.
Well, thank you. This has been a very, very interesting panel, and I'm so glad to hear that there'll be a white paper that comes out of this. And I guess I want to challenge you to help this white paper really tackle the issues that surround inquiry and screening for issues of violence and abuse, and using elder abuse as a good example of that. I think the discussion of tools the one question versus the many questions, how to make it patient-centered, how to make tools so that it really facilitates clinician behavior change. These are really critical. Measures. We could spend a whole bunch of time talking about the pluses and minuses of measures and how they drive or don't drive behavior. I spend my life in a large healthcare organization like Kaiser Permanente focused on how do we improve the patient experience in areas around sensitive topics like this? How do we change provider behavior? And there's been lots of learnings, I think, from us and other healthcare plans about what are the benefits, what are the problems, what are the unintended consequences of all of these things. So I think a really educated white paper will really drive this field forward. So I commend you to do it in a thoughtful and, well, I am not even sure about a hurry exactly. I'd like it to be soon, but doing it thoughtfully, I think, is what will be most helpful to all of us in all these areas. So thank you.
Thank you.
And
Yeah, I think the real focus has to be why so few physicians pick it up. And you have a great instrument, but the doctors aren't doing it. You got to change the doctor's culture. And that's where you need some qualitative work to see how are you going to do it. Because no matter how good the instrument is, if only 10% of doctors or less are using it, it ain't going to do any good. So you got to have a focus on that.
right, and
There's
actually,
one
on
more
the-
piece here, which is one of the biggest learnings we've had is that the context in which that screening or inquiry takes place is perhaps more important than anything else. Because if it's not done in a private way that ensures some trust and confidentiality, what looks like a really good tool turns out to not really get you what you want. So both the tool, the incentives for providers, the context and so forth are really important. Thanks.
Thanks, Bridget. And I know on behalf of CMS, I know part of our intent in terms of expanding this measure is to make it more patient-centered and to be driven more towards an outcome-based versus a process-based measure, so that we're getting more quality in terms of what we're yielding from the outcome.
If I could respond to your comment, Michael, I think you're absolutely right. We need more physicians engaged in this. And as a physician, I say that quite strongly. However, I'm also cognizant of the fact that about 3 years ago, there was a very fine paper, and I regret I don't have the reference with me, that identified that for a primary care doctor, there are about 73 clinical practice guidelines that they need to attend to on a yearly basis with their patients. And if they attend to that, it'll account for 6.5 hours a year with those patients. So yes, my right hand says the physician should be doing it. My left hand says I'm aware of how difficult it is to do. So it boils down to discussion about physicians plus or minus other health professionals and at what frequency this needs to be done. The point that we make about the EASY tool is, and again to Ron's comment about its relatively low sensitivity, we don't expect to have high sensitivity, but if the tool is used frequently enough and we see the patients frequently enough, we're going to get the responses. So it's a question of, do I as a physician ask this on one of the 5 visits a year? That to me is going to be pretty good. If I can do 3 a year, then I'm outstanding. I'm not going to reach that.
Well, no, I
5
was
seconds.
just going to say, in terms of Michael, we agree with you completely. I think one of the other problems from the United States perspective is that the physicians are then obligated, if they obviously then identify some type of abuse, then there's that whole level of APS to which, in fairness to a physician, they don't want that.
fear.
Yeah, I mean, they don't
It
want to
creates
go
fear.
down that road.
So it's a culture change within the physicians again, is
Totally.
what we're talking
Yes.
about. If that
Yes.
doesn't happen, the best two.
Correct.
Yeah, and I think we can certainly continue this discussion. And I fear of my next panel throwing sharp objects at me, or even greater risk of you losing your lunch. I want to thank the panel very much.
Thank you.